Today's presentation is an evidence-based practice or EBP project proposal in reducing the COTI rate in a Veteran Health Administration long-term care facility. In long-term care facilities, about 20% of the reported infection are related to catheter-associated urinary tract infection, or COTI. COTI is a preventable illness that causes the United States to spend up to $1.8 billion annually. Now, one of the long-term care facilities of the Veteran Health Administration, it has a COTI rate that is significantly higher compared to the national average. This signifies that the VHA facility was lacking in the policies and procedure to appropriately manage the use of urinary catheters. The purpose of the Evidence-Based Practice or EBP project is to establish a plan to decrease the incidence of COTIs in the veteran health facility by changing the standards of care based on current evidence. Before we proceed, let us understand the pathway of how a patient can commonly acquire urinary tract infection, or UTI. Urinary retention is a condition when a patient loses its ability to effectively empty its urinary bladder. It is important that the urinary retention is addressed because it can lead to severe or fatal complications. When urinary retention is not managed by non-invasive intervention, an effective way to treat the condition is by using urinary catheters. However, evidence suggests that the risk for COTI increase with the number of days the urinary catheter is used. The problem with the VHA facility, the indwelling urinary catheter was highly utilized for extended number of days. This has led to high COTI rates as evidenced in the quality indicators from the Medicare website. Looking at the clinical question, the EBP project proposal is an attempt to change the policies and procedures of the VHA facility through the implementation of the EBP process. The EBP implementation will utilize a systematic approach of managing COTI by reducing the use of indwelling urinary catheter through the utilization of intermittent urinary catheters. The next important step of the EBP project is to search and synthesize the most appropriate evidence to answer the clinical question. Based on a comprehensive review and critical appraisal of the research studies, it shows that there is no enough evidence to support that either an intermittent urinary catheter or indwelling urinary catheter is more effective in reducing COTI. However, there is supporting evidence that intermittent urinary catheters allow the patient to recover with urinary retention faster compared to the indwelling catheters. There's also a strong evidence that intermittent urinary catheter can prevent long-term complications of the indwelling catheters. The proposed EBP implementation is a three-step process of urinary retention management. The first step is for the providers to determine the appropriateness of the intermittent urinary catheter, because not all patients are appropriate for the intervention. If the patient is appropriate for intermittent catheter, step 2 is to make the intervention as the primary option to treat urinary retention. Then step 3 is to manage the intermittent urinary catheter according to the CDC guidelines until urinary retention is resolved. However, if step 1 determines that the patient is not appropriate for the intermittent catheter, the next step is step 3 following the CDC guidelines in managing the indwelling catheter. With the indwelling catheter in place, the provider is required to reassess the appropriateness of the intervention every 30 days. This means that the physician will once again follow the three-step process starting with step 1. The idea of the EBP implementation is to keep following the process until urinary catheter is discontinued. The concept of the EBP implementation is to keep following the EBP three-step process until the urinary catheter is discontinued as early as possible. When there is an active intervention of reducing the use of urinary catheter, it will also reduce the incidence of COTI. In the EBP project, there is a need for strategic implementation. According to studies, about 50% of organizational change initiatives and 81% of cultural change efforts were not successful. This signifies that any change efforts or EBP implementation will most likely fail without the proper strategy, planning, and systematic method. For the EBP project, the Cotter change model will be integrated into the implementation process. It is about utilizing the see, feel, change principle that will allow the stakeholders to be emotionally engaged in bringing change. To effectively implement the EBP project, it is important that all stakeholders are clear with the expectations and their responsibilities. It is vital that the EBP core group will create a detailed plan and timelines of the EBP implementation. An important element of the implementation is to eliminate fear and anxiety by providing a consistent and dedicated EBP mentors for the first 2 months of the implementation. Another strategy is to practice shared governance with the stakeholders. Instead of demanding change to staff members, this is about empowering the stakeholders to be an active participant in creating the change process. Another important process is data collection. It is the way to measure the progress of the EBP project. The data collection process will be divided into two categories. The first category is the monitoring and tracking of the external data of the COTI rates from the Medicare website. The goal is to decrease the COTI rate to a comparable percentage to the national average within 6 months. The second category in monitoring is the internal data from the EBP implementation process. The goal is to reduce the COTI rate and the device utilization ratio to 50% based on the prior data before the EBP implementation. One of the most important data in the EBP project is obtaining feedback from the patients and staff through survey questionnaires. This will help the practitioner to align the EBP implementation with the patient's preferences. After gathering the measurable data, this will allow the practitioner to evaluate the progress of the EBP project. For an EBP project to be truly successful, it is necessary that a methodological process to measure and evaluate the implementation is fully established. As what the famous mathematician William Thomson said, if you can't measure it, you can't improve it. In evaluating the project, the practitioner needs to determine if the EBP implementation is enhancing the quality of care, improving patient outcomes, reducing cost, and empowering the staff. If these elements are not truly met, it means that there is still room for improvement. Thank you for listening. It is now time for question and answer.